Yeah, we are live.
Okay. Good evening, everyone. Welcome to day 5 of MLRW 2023, brought to you by IDG.ai. Today, it's my pleasure to welcome our esteemed guest, Dr. Alpan Raval. He's the Chief Scientist AI/ML at the Wadhwani Institute for Artificial Intelligence. A theoretical physicist by training, he taught math and computational biology at the Claremont Colleges in California. He has also worked for the research and AI teams at DE Shaw Research, Amazon, and LinkedIn prior to joining Wadhwani AI. For all those who are unfamiliar with Wadhwani AI, I must say they are definitely a pretty unique organization, a one of a kind in our country. They're an independent, non-profit institute that develops and deploys AI-based solutions for underserved communities in developing countries. So, in today's talk, Dr. Alpan Raval, who is the chief scientist at Wadhwani AI, will share his valuable insights and perspectives on how AI can be leveraged to tackle various societal challenges in today's age. So, without further ado, over to you, sir.
Thank you, Mihit, and thank you, IITG.ai, for this invitation. I know I was supposed to speak maybe last year as well, but somehow it didn't work out. So I'm very glad that it worked out this year. Um, this talk will be a broad overview of the work we are doing at Wadhwani AI. Um, so before I get into it, I'd like to sort of define what we mean by AI for social impact. We are an AI for social impact organization. Um, Now, as you all know, all of you are probably AI practitioners, you code every day, and you probably know about the impact that AI can have. Now, especially across the developing world, there are societal problems that affect lives and livelihoods. And these problems, especially as we evolve, as technology enters our lives in ubiquitous ways, these problems are complex, they're dynamic, and they're all interconnected with each other. And they involve a lot of data necessarily. So AI is a technology with its ability to use disparate data to amplify decision-making systems and uncover these complex correlations that exist in the data, is a technology well suited to solve many of modern society's problems. But the problem is that deployment, adoption, and the impact of AI models when it comes to solving problems that affect lives and livelihoods is really limited. And the idea behind AI for social impact is to address this gap. Now, there's another term that's widely used, which is AI for social good. And we think of AI for social impact really as a subset, in a sense, of AI for social good with some disjoint component. For example, AI for social good increasingly has come to mean the resolution of negative effects of large scale AI, right? And especially with the launch of large language models and so on, this discussion is only going to grow. And these negative effects relate mainly to things like fairness, bias, inequity, and so on. But these are, in a sense, post hoc effects. These effects arise after you've already deployed AI models at scale. And the only place where you see AI models deployed at scale mainly is affluent areas, right? So, in a sense, AI for social good is a safety valve or a mitigation system that really only helps the affluent. And we feel that AI for social good really needs to be made more relevant to the primary needs of the developing world, of underserved communities, and hence we distinguish AI for social impact from AI for social good, right? So the main priority of AI for social good is that improvements in life and economic conditions for underserved populations are a first priority, and everything else is secondary. So this brings us to what kinds of problems we should tackle in the AI for social impact space, and that naturally leads to a discussion of the UN Sustainable Development Goals. For those of you who are not aware, these are 17 goals that are set by the United Nations, and the original aim was that these goals should be met by 2030. They were set in 2015. And these goals can be clustered into three thematic areas that affect society, like poverty, hunger, and so on, areas that affect the economy, like employment and so on, reduced inequality in the workforce, and so on, and areas that affect the environment, like climate action and so on, right? The problem is that we are, I think it's safe to say that we are behind on all of these 17 SDGs, and we are not going to achieve them by 2030 across the world. So, and in fact, developing country targets are much more far off than developed country targets. Some examples are poverty. The COVID pandemic, as well as the Ukraine crisis, have really derailed progress on extreme poverty. Food supply has not progressed at the rate it should. Disease is endemic. COVID, of course, you know about, but even progress against TB, malaria, HIV, this was slow to begin with, and it's been further derailed by the pandemic. There are 10 million TB cases diagnosed worldwide every year. 30% of them are from India, and this is expected to, well, this is a sort of an old statement. It actually did grow a little worse in 2022. Now, where does AI come in? So there was a study about 4 or 5 years ago by the McKinsey Global Institute that mapped AI algorithms or AI methods to different UN goals. And it's clear that, most UN goals, UN Sustainable Development Goals, can be impacted by the use of AI. And what they found back in 2018 is that there were about 160 deployed AI solutions across the world that directly map to the UN Sustainable Development Goals. Now, of course, that has probably increased significantly by now. I don't know of a similar study that has been done recently, but I would imagine that even if you assume that's increased by tenfold, say to 1600, it's still a small number. And so the addressable space for using AI that affects the SDGs is huge. And the same study actually analyzed the positive impacts of AI versus the negative impacts of AI. And the overall consensus was that the positive impacts far outweigh the negative impacts. The negative impacts are things that we already know about, like training AI models requires high energy, has a huge carbon footprint. AI models are known to amplify biases. You can use AI for, dubious things like surveillance and creating citizen scores and things like that. Um, there's a lack of diversity in most data sets that AI models are trained on, and the AI workforce itself has lack of diversity. We don't have enough women in AI. And of course, the fear of job loss because of rampant AI, and this fear would only have increased with the emergence of systems like ChatGPT and other foundation models. But of course, we have mitigation for many of the negative effects. There's a lot of active work going on in the area of green compute, human in the loop to safeguard AI decision making, control deployments, better data preparation, upskilling, diversity enhancement, and so on. So these are addressable issues, right? They don't take away from the fact that there are a lot of positive impacts to be had by analyzing data the way AI does. So with this background, I sort of come to what we do. So we are an independent, non-profit, cross-domain AI Impact Institute, as was already mentioned. By cross-domain, I mean that we work across various thematic or programmatic domains. We work in healthcare, we work in agriculture. We've just started working in education and climate change mitigation as well. And our charter is really to develop and deploy AI-based solutions to create impact at scale across the global south. And these are solutions that will preferentially impact underserved communities and impact their lives and livelihoods, and only in the global south. So our charter is limited to global south. It's limited to the use of AI and to underserved communities. So we have rather ambitious goals. I'm not going to go through this entire slide, but just summarize it. We have rather ambitious goals. We aim to develop and deploy AI applications that will impact 800 million people by 2027. That's 4 years from now. And the way we do this partly is by establishing AI centers of excellence within various government departments as well, in order to discover problems, discover data sets, discover deployment pathways. So we have this two-pronged approach where we have teams that are deployed within within government departments, and then you have the back-end AI team which works on the problems. And in fact, we found that this approach works very well, both in terms of problem discovery, as well as in getting access to interesting and unique data sets. And we're, from the government point of view and from the point of view of most of our partners, we are seen as the only nonprofit applied AI institute that provides these types of custom solutions. So this whole sort of two-pronged approach has resulted in a large number of collaborations. We collaborate with government departments, with various institutes, and we have MOUs with all of the institutes that you see mentioned here, and they span various activities ranging from defining problems to data collection. Um, for AI modeling, we have collaborations with many of the IITs and with Harvard and CMU. And then, of course, deployment and evaluation, we partner externally. Our approach to each project is very multidisciplinary. So for each project, we bring together a team of people that has representation from different backgrounds. So depending on the area in which we work, there is a domain expert for that area. That domain expert could be a doctor or an agricultural expert or a climate expert, and so on. We have AI/ML scientists, obviously, who work on the modeling aspects. We have a user research and design team that look at how the model will be used on the ground by the beneficiaries and what the interface is in terms of usage, and they design these interfaces. We have obviously engineering that helps in building apps, data pipelines, etc. And we have a monitoring and evaluation team that looks at how we will evaluate not just the accuracy of the model, but also the impact. So this is a sort of bird's eye overview of what we're working on currently. This list is increasing, I would say, week by week and month by month. So this is an already dated list since I made this presentation. And what I'll do is I'll be talking about 3 examples of our work going forward. But first, I'll just give you an overall idea of what we're doing. So 3 main domains at the moment. One is healthcare. The other is we are bundling agriculture and climatic work together, and education. In healthcare, we already have a learning-based clinical decision support system integrated into the government's e-Sanjeevani system. That's basically a symptom checker system. And what it does is it looks at patient-reported symptoms, it prompts them for more information. So there's a smart interactive form, and then after prompting for the information, it provides a set of putative diagnoses to the doctor at the other end. So this is all telemedicine. We are working with the National Health Authority to do automated claims adjudication for PMJAY, which is one of the largest health insurance schemes in the world. In the TB space, this is one of the oldest spaces in which we've been working. We have 5 different AI solutions that span the entire cascade of TB care. And I'll go into 2 of these in some detail a little later. In the maternal, child health, and nutrition space, we're working on 3 different projects. One is a very old project that you'll hear about that has to do with newborn anthropometry, where we take videos of babies and can infer their weight. We are doing disease outbreak monitoring through a web crawling system that looks at local news articles on the web and extracts information out of them and reports possible events of interest. And these events of interest are typically either disease outbreaks or public health related matters, like a food poisoning situation or a water poisoning situation, and so on. And all of these things are reported into a central cell in Delhi, which is called the Integrated Disease Surveillance Cell. And then the central cell is sort of the human in the loop that takes a final decision on taking action basis the recommendation of the AI. In the agriculture and climate space, we have a AI-powered pest advisory for cotton farmers. And the way this system works is that there's a demo farm. Typically, we identify a demo farm in a village. A demo farm is a farm that's owned by a farmer who has a smartphone and who can afford to buy a trap. The trap is installed. This is a pest trap that's installed in their farm, and pests get attracted to the trap, and lots of other things also get attracted to the trap. And through our app, you take a picture of the trap, of the contents of the trap, and through segmentation, the model estimates pests, the presence of pests of different types, counts them, and based on the pest counts, then recommends whether the farmer should spray pesticide or not in real time. And this doesn't require internet. The model actually sits on the phone. We're also working in a number of other areas in the agriculture space, some of which you see listed here: digital, and a sort of digital farmer diary using a voice-based system. Crop yield estimation is a long-term project. It's a very difficult problem. We just started working on it recently. Automated call centers for farmers using voice-based conversational AI systems. Agriculture news monitoring, very similar to the disease outbreak monitoring. And then two sort of climate-related areas that we are getting into, which is estimating soil organic carbon and invasive plant species from remote sensing data. In the education space, we're looking at developing models that will help reduce school dropouts. So if you have the ability to predict in advance whether a child will complete will complete their year at school, or will they drop out somewhere in between, that's very useful, because then directed interventions can be taken. You can have teachers or school officials going to children's homes and advising their parents, making sure that they come to class. Um, so we've just started working on that. We've also made a basic model to do automated oral reading fluency, where a student reads a piece of text, and then the model analyzes where the student made mistakes and then assigns a fluency score. And of course, once you have voice data from students reading things, we are collecting this voice data from across the state of Gujarat right now. Once you have this voice data, that's very rich. You can potentially do a lot of things with it. For example, you could diagnose various learning difficulties just by looking at where students pause, when they speak, or how slow they speak, or how fast they speak, and so on. So all of these projects are going on, and the space of projects that we are working on just seems to be expanding every week. So I'm sure I'm missing out things over here. So what I'm going to do next is sort of talk about a couple of our TB projects, projects in the TB space. And then I'll talk about one project that we're doing in the maternal and child health space. And I think by that time, we'll be at time. So TB is a problem that's especially relevant for India. You may have heard in the newspaper that when COVID struck, TB was neglected. That is in fact true. TB's traditionally been a much bigger killer than anything else in India, certainly more than COVID. And there's a whole cascade of TB care, and this is the cascade that you see depicted on the right here. So the cascade is, you have new active TB cases. Many of them are not diagnosed, so they're not detected or reported, and so on. So you lose patients. Potential TB patients, simply because they don't go to a clinic, or they go to a clinic and they're not tracked, so they eventually don't complete their medication. Things like that. There are many who go to a clinic, they get diagnosed accurately, but don't never start treatment. Then there are those who start treatment, but don't finish treatment, right? And because of that, that leads to other complications. And finally, there are those who finish treatment, but the treatment is not effective, which is really a very small population. I mean, in general, TB is a curable disease. Especially drug-sensitive TB is a curable disease, but it can get nasty very quickly if you stop taking your medication. So the estimate is that if you have a 6 month drug regimen to cure, to address TB, and you miss about 10% of your doses, then the chance of getting drug resistant TB is increased by a factor of 3. And once you have drug resistant TB, that's much more difficult to cure, that has a very high mortality rate, and so on. And that's usually the reason people die of TB. So it's estimated that because of all these effects across the cascade, at any given time, we are missing about 500,000 patients who actually have TB, and they're just not being treated by the system, in spite of treatment being available, and in spite of the fact that treatment in India for TB is free. It's provided for free by the government. So we were very interested to see how AI can help, especially because a lot of the data surrounding TB, so a lot of the patient line list data, the longitudinal data for patients is in fact logged into a central database called NICSHI. And so by law, every patient who is diagnosed positive for TB has to be notified into NICSHI and tracked through NICSHI. So every interaction that patient has with the health system has to be logged into NICSHI. So this data exists, and so we thought, we could probably do interesting things with it that could address, that could help alleviate the burden of TB. So the first sort of model I'd like to talk about is one where we try to predict loss to follow-up and mortality in TB patients. And I'll describe what this is. This is the team that worked on the model. And it's currently piloting. It's about to pilot in Mumbai, actually. So the problem statement is that one of the big issues in TB, as I already mentioned, is non-adherence to medication regimen. Right? So in fact, if in 2021, for example, 4% of TB patients were lost to follow-up. What that means is that they just dropped off their treatment. After a point, it's a 6-month regimen. Say after a month or 2 months, they don't come back to collect their medication anymore. They just drop off the system, and that's called LFU. And of course, mortality is somebody dying. So it turns out that LFU patients also are much more likely to die because they don't complete their medication regimen. So the idea was, with AI, we could do early identification of TB patients who are at risk of LFU, as well as other outcomes like mortality, and we could do this right at the onset of treatment initiation. And the data we used for this is NICSHI data. So it's a classic tabular data problem. We expect that with the current solution this year, that about 100,000 patients, 1 lakh patients will benefit. If the solution is deployed at scale across the country, you could potentially avoid close to 1,500 TB deaths per year. So the way this works is we extract 2 tables or registers from the NICSHI database. This is the notification register and comorbidity register. The notification register contains variables like the age, gender, weight of the patient, the location, the history of drug resistance, the site of disease, the treatment history. The comorbidity register contains details about the tobacco addiction, alcohol addiction, any other kinds of diseases they may have, and so on, like HIV, for example, their susceptibility to drugs, and so on. And we put all this into a tabular data model. So this model was trained and tested on about 1.6 million, 1.7 million patients. 75% of that data was used for training. And this wasn't a random subset. We actually did a longitudinal split where we took data in the past for training and tried to predict LFU risks for patients in the future. So the idea is that you have the model assigns a risk score to every patient. Um, this is sort of quite standard for those of you who know machine learning. Patients are reordered in descending order of their risk scores, and then depending on and this is the important part here. You could of course identify a cutoff and say anybody who is above that cutoff is likely to go LFU. The better way to think about this is to look at the resources that are available locally within the TB health worker system, and ask, how many people can you deploy to take interventions. So in other words, if you identify a patient as high risk, what are you going to do? And typically what you do is counseling, right? You make sure the patient takes their medication. And then the question is, what percent of patients within your local catchment area can you support through counseling? And so you have a variable cutoff problem where, say, if you target the top 10% of your patients because you only have that much health worker resource, then you can ask, well, if I were to target the top 10%, then how many of the, what would be my recall? How many of the true LFU patients would I correctly identify? So it turns out here, if you target the top 10%, your recall is 40%. So you're already capturing 40% of the patients who will go LFU, and so on, right? So you can keep doing this depending on what your health worker resource is. You can shift the threshold. So from the ML perspective, there was a lot of data work in this model. The raw data is simply not usable. It's very noisy, so we had to do a lot of data cleaning. We had to do imputation, so we built imputation models as well. There were some columns that we simply had to remove because the um prevalence of NAs in those columns was extremely high. Then there were data leakage issues. There were correlated columns, which led to data leakage issues. So we had to remove those as well. We experimented with a whole bunch of encoding and data augmentation techniques here, because this is very high cardinality categorical data. So you simply can't use one hot encoding. These models don't work very well with simple one hot encoding. So we had to try all kinds of encodings there. As I mentioned already, we did forward splits with the data. We left 6 months of data untouched for evaluation and trained on the rest. Um, we Our best model is an ensemble model, but of course, being an ensemble model, it's also not the most interpretable model. And of course, various types of techniques for hyperparameter search and so on. We did very extensive evaluation of this. We did evaluation across cohorts. We made sure that we incorporated fairness. We made sure the model was generalizable. It generalized to all kinds of populations and it was robust. And in fact, I think largely because of the detail at which we did this evaluation, we won the. I mean, this work won the best paper award at the ML4H workshop at NeurIPS last year. So yes, so as I mentioned, this is how it works. You take a combination of Nikshay and demographic data and do the prediction. And then the idea is that this prediction would be available in an app and accessible to TB field staff so that they can use this to do further interventions with patients. On the right, you see performance metrics. And the way we report performance for this is recall as a function of targeting. I already explained what targeting is. It's the K percentage is the amount of health worker resource that you can spare in order to do these interventions. So, how many patients can you target? What percentage of the number of true positives can you target? And so you can see that most of the ML models, there's a whole class of ML models that we tried, they all overlap on the top curve. They do reasonably equally well. A rule-based model that's based on 10 different features which is in fact even more sophisticated than the standard model that's used in the field. Actually does far worse. That's the pink curve here. Does far worse than any of the ML models. And of course, the random model is the straight line. These tables actually compare sensitivities and specificities using the rule-based 10 covariate model versus the machine learning model. And you can see in all cases, the ML model is significantly better than the rule-based system. So the idea is, in an ideal world, every patient needs to be counseled, and in fact, the Ministry of Health and Family Welfare mandates that every single TB patient must be followed up by by a TB health worker. In practice, it's not possible. So our AI system, because it sort of differentiates patients by their risk score, really helps support the whole TB field staff work. And the overall understanding we have with the TB program is to target at 35%. And what we find is, using the current model, if you were to target the 35% of patients in a randomly chosen catchment area, you would save 74% of the patients from loss to follow-up. The next,
Sorry to interrupt you.
yes,
I had a
sorry, I
question.
can't see any questions because
No,
I'm
that's
on
all right.
the.
I'll tell them to you. It's all right.
Sure.
So we had a question is like, could you explain why boosted trees ensemble were used over neural nets?
Oh, we tried neural nets. So neural nets are, they haven't been shown to perform well on tabular data. We tried actually various versions of tabular neural nets. None of them work as well as boosted trees. There's work going on using language models to do predictions with tabular data. We haven't tried that, but generally neural nets don't work well on tabular data.
Yeah, that's all the questions that you can.
Okay. Yes, thank you. If you can just tell me the question and it works. Just feel free to interrupt at any time.
Sure.
The next problem that I want to talk about is ongoing work. It's not completed work. It's, in fact, we're still collecting data, but it's an interesting problem. And the idea is to screen for TB using cough sounds. And there are a lot of groups working in this area of using cough as a way to diagnose TB, COVID, many other diseases. In fact, we worked on the COVID problem as well earlier. Many of the other techniques that are being developed um, are often developed in idealized conditions. So, for example, you need to be in a silent room, or you need specialized hardware attached to the recording device. In this case, the recording device is a smartphone, or you need a fancy phone or something. The way we approach this problem is we want to be able to use it in a community setting in rural India, where people don't have fancy smartphones. They may have a very simple Samsung smartphone. So we wanted this to work on a very simple smartphone without specialized hardware of any kind, within a noisy environment. So we bounded the problem that way, and we've done the data collection also accordingly. So I'll just explain the problem and then the way we are looking at it. So as I mentioned already, in India, out of every, like, the ratio is 1.8 out of 2.8 cases that are prevalent in the community are actually missed by the public health system. And then there's an estimated 64% of cases that don't seek care in spite of having TB systems. So the idea is that if you can increase the top of the funnel for catching TB patients by having an easy system to screen for TB. So we are viewing this as a system that screens for TB, not diagnoses. And the difference between screening and diagnosis is that in a screening tool, you can tolerate false positives, but you can't tolerate false negatives. So in other words, you may say that a number of patients who actually don't have TB, the screening tool may say that these patients have TB, but it doesn't miss any patient who actually does have TB. That's the idea. So the way screening tools typically operate is you take a screening test. If it's positive, the patient is asked to go for a confirmatory test. That's a diagnostic. If it's negative, then the patient doesn't need confirmatory testing. So it has to be very accurate in terms of diagnosing negative patients accurately. Right? Um, so the idea is to use this as a screening tool because it's something that can be easily deployed on the field. Right? All you need is a simple smartphone. Currently, this is already deployed in Nagaland. We are working on also deploying this in Tamil Nadu to a limited extent. So we see this working in two different settings. Either and these settings basically reflect the way we've been collecting data. Presumably, it could work in more general settings as well. It's just that we haven't tried it. We haven't evaluated it in a general setting. So the two settings in which we collect data are either individuals who have a complaint and visit a health center, or individuals that are contacted during home visits by the community health officer. Now, typically, the individuals who are contacted during home visits are relatives of TB patients. So they turn out to be people who are close to a TB patient. So this is not a general sample. It's not the general population. The prevalence of TB in the general population is extremely low. It's less than 1%. So you don't get much yield if you just go into the general population and start collecting data. Your prevalence of positives will be extremely low, which is why we restricted data collection to these two populations. Okay. And then the idea is that we collect cough samples as well as self-reported symptoms. These are not symptoms that a doctor enters, but self-reported symptoms from the patient into our app. And then the AI models analyzes both the cough as well as the self-reported symptoms in order to come up with a score. So these are some of the app screens. They're very standard. So these are the self-reported symptoms that are collected, like did you experience chest pain in the past 6 months? Do you drink, etc. And then the app asks you to record a cough sound. So these are solicited cough sounds. The patient doesn't have to be symptomatically coughing. They just have to, force themselves to cough 3 times. And they don't have to cough into the phone. I mean, obviously there are hygiene reasons that you shouldn't do that, but they can cough in the vicinity of the phone. That's good enough. They can even wear a mask while coughing. That's good enough. And then the phone gives you a recommendation on whether you need further testing or not. Right? That's the inference. Yeah. So these are the various. So you have 3 cup. The input data is 3 cup recordings, these self-reported symptoms, and a bunch of comorbidities. Do you have diabetes? Do you have COVID? Do you drink? And do you smoke? That's it. These are all sort of yes/no features. And then the model is essentially the cuff sound is chunked into windows. They keep experimenting with the length of the window, so I don't remember what the current length is. And then we create a spectrogram out of each window. The spectrogram is then fed through a ResNet 18 backbone, and in addition, we have some fully connected layers following the ResNet 18 backbone. And independently, there's a separate flow that takes the symptoms and runs it through a XGBoost tabular model, and then these two models are ensembled to come up with a result. All the different chunks of cuff sounds are also aggregated into this signal, and the 3 different cuff sounds independently are also aggregated into this signal. So these are current results, and this is based on about 7,000, I think 6 to 7,000 individuals cuff sounds collected. And this, in fact, this collection is ongoing. So what you see here is sensitivity again versus the same type of K is the number of individuals who can be tested through further testing, because there's a limitation. There's sort of uh, a limitation that's dictated by the health system in terms of the number of individuals they can process in secondary testing. So that's what we use as the way to choose thresholds for this. Um, the dash line that you see here is a rule-based model that's based on the symptoms alone. The orange curve is the ML model, and the blue curve is sort of what a perfect ML model would achieve at the prevalence that we have in the data set. So this is, I think, these results are for. Yes, this is for individuals visiting a healthcare center. And the AI model does reasonably well. It does significantly better than using just symptoms alone, and which is why it's been deployed in Nagaland. But we believe it can do even better as we collect more data and do more experiments with the model. So, in fact, in some ways, if your testing capacity is low, it's actually complementary to the rule-based 7-symptom model. And here you can see overlap. So, depending on your testing capacity, so say if your testing capacity is 20% in a population of 1,972 people, um, if your testing capacity is 20%, then this is the number you would send for testing. And this is the number that's identified by the AI. This is the number that's identified by the rule-based model, and then the overlap. And you can see as your testing capacity increases, the overlap also seems to increase. This is a separate evaluation cohort, which is tested on community data from TB contacts. So these are contacts, meaning relatives of patients who have TB. So this is a different test cohort. And again, you see overall, at least for K values that are not very large, the ML model does significantly better, but this data set is much smaller. We don't have enough data from this cohort as yet. And so you can see the data set is very small, a total population of 386, out of which only 15 are TB positive. So there's not much you can infer, but still the trend seems to be clear that the ML model does better than a rule-based symptom screener. And in fact, I should mention that this 7-symptom screening is a very popular way of screening for TB. So any method that's almost equally easy, which this method is, but gives significantly more yield than a 7-symptom screening method, is something that's taken seriously in this business. So as I said, this is ongoing work. We clearly need to collect much more data from the community, not just from people visiting health facilities. The last solution I want to talk about is a newborn anthropometry solution. And here the context is so there's some context I'll have to explain in words. So you may have heard that 80% of babies in India are actually born in a hospital now, which is quite remarkable. I mean, this includes rural India, this includes backward areas. The problem is, so when the baby is born in a hospital, it's accurately weighed typically using a digital weighing scale in a hospital. The problem is the moment the baby goes home, their weight is not tracked accurately. The way the weight is tracked is typically an ASHA worker who's typically a worker employed by the government to go door to door and do counseling, assess malnutrition and so on. What they do is go to door with a spring balance. They use the spring balance to weigh a baby. These spring balances are not well calibrated. They are not properly eyeballed, and then they write down the weight on a register. There's a WHO guideline that any baby that's less than 2.5 kg within the first 28 days after being born needs other interventions. So they need nourishment. And so if a baby is found to weigh less than 2.5 kg, the ASHA worker has to do a lot more. in terms of notifying the system, notifying medical professionals, and so on. Because ASHA workers are overworked, they tend to round up the weight. So if the weight is 2.2, for example, it will be rounded up to 2.5. So if you look at these data sets, if you look at data sets of weights of babies within the first 28 or 42 days after birth, and you plot a histogram of this data, you typically find that there is a huge spike at 2.5 kg for this reason, because ASHA workers are overworked, and if the baby looks okay, they're just going to write 2.5 so that they don't have to do additional work. So this is really the origin of this problem. The question was, is there an effective way to measure baby weight in the field, in a rural setting, without taking complicated hardware along? Digital weighing scales are not an option. They're expensive. They need to be calibrated frequently, and so on. ASHA workers cannot carry them door to door. So this is the genesis of this problem, and what we thought was a potential way to tackle this would be through computer vision. And in fact, this is what we do. These are just some statistics. 3 neonates die every minute in India. Neonates are babies, I think, less than 42 days old. And every fourth baby born is low birth weight, meaning less than 2.5 kg. And then various statistics that are, very sobering. I mean, 40%, for example, 40% of low birth weight babies born worldwide are born in India, and 27%, or every fourth baby, is low birth weight. And neonatal mortality rate in India is 22.7 per thousand births.
Yeah, sorry to interrupt you. We actually had a
Sure.
question with the previous project. Does
Yeah,
the
yeah,
cough
sure.
does the cough sound data differ on person-to-person basis, like gender, age, etc.? So any steps taken to pre-process the data?
Well, it's standardized in terms of chunks. So the chunks have a fixed length. So every person coughs differently. That is true. And in fact, even the total length of the cough stream is different. But the chunks all have a fixed length.
All right.
That's the reason we divide up the data into chunks. And then anyway, the inferences from each sort of window are aggregated at the end.
Another question was like, do
I
you
don't think there's
face
much other. There's some volume normalization and so on that's done to standardize, but not much else. Yes. Sorry.
do you face issues with running model inference in like rural areas where there is no internet connections and those sort
Yeah.
of issues?
Yeah. So
How do
in fact, there's a requirement. Some of these models, I'm not talking about agriculture work, but a pest identification model, there's a requirement that it has to fit on a smartphone. So we did a lot of model compression experiments there. For the cuff model, as yet, we are not doing compression experiments. We want to make sure that we collect enough data and have the model be robust enough. So currently, it's still sitting on a cloud, but sitting on a cloud server. But the idea is eventually to compress it so that it fits into it fits on a smartphone without compromising accuracy.
Yeah, thank you. Those are all the questions.
Sorry.
Yeah, that's the another question you can.
Okay. I mean, we can get into a discussion at the end as well.
Yeah, absolutely.
Yeah. So the idea behind this anthropometry solution is that the ASHA worker or health worker takes a video of the newborn using our app, which we call Visual Weighing Machine. The model estimates the weight as well as some other parameters like height and chest circumference and head circumference and so on. Based on the weight, so the health worker can make recommendations in real time there and then to make sure that the newborn gets appropriate care. But also, more importantly, the weight is logged in the backend in a tamper-proof way. It's not just enough for this system to be accurate, but also the fact that it enables automatic digitization, which you don't get with weighing scales, is very important. So the ASHA worker cannot change the weight, cannot tamper with the number. It's automatically logged in the backend, and there's a lot of aggregate analysis that can be done in the backend. At the community level, for example, to identify communities that consistently have low birth weights and things like that. So a lot of things can be done with this data. Um, so basically, the idea is to replace spring balances with tamper-proof and automatic digitization, which is still accurate and more accurate than spring balances. Um, so this is an overview of the app. I don't need to get into this. I'll talk a little bit about the modeling approaches that we take. So in the past, we've looked at two broad sets of modeling approaches. One is what are called model-based methods, and these are methods that attempt to fit a deformable mesh to the baby shape. And so the idea is that you pass the video through a CNN, which then infers various shape and pose parameters, and then you infer a mesh for the baby. So from the 2D data, you infer a 3D mesh. Then you measure the volume inside the 3D mesh, and you multiply by density to obtain weight. This is the approach we were using earlier. The reason you might think that could be successful is because babies apparently have very uniform density, much more so than adults. So this is the approach that we had originally taken. It turns out doesn't work very well. We think that this approach probably did not work well because it's extremely data hungry. On the other hand, the more obvious approach tends to be the approach that works much better, which is that we just pass this through a CNN, get frame level representations, aggregate these representations for different frames, um, and then regress directly on the weight of the baby. So there's no volume estimation in between. We just regress on weight and other other outputs that we need, like length, chest circumference, head circumference, and so on. So these are the two sort of basic high-level approaches. Model-based methods is approach one. Model-free methods is approach two. And all our work so far, except for the early work that we did, which did not work very well, most of our current work is focused on model-free methods. And within model-free methods, over the last year, the directions that have been most promising are multitask and contrastive learning. So in multitask learning, we in fact simultaneously predict various things, and that turns out to be to improve the accuracy of each, right? So for example, we do one of the tasks is baby anthropometry. In other words, predict weight, height, various lengths, and so on. In the second task is to predict a seg mask that identifies the baby in the image. And the third task is to predict various key points on the 2D projection of the baby. It turns out when you do these three tasks together, you actually improve accuracy on task one significantly. So this is something we've discovered in the past year. The second approach that is ongoing but has also yielded good results is a contrastive learning approach, where we force the representation of the video. We force babies of similar weight to have similar representations in feature space. So there's a standard contrastive learning approach, and babies of different weights to have different representations in feature space. So currently, if our results in a hospital setting, so a hospital setting is a setting where you have uniform lighting, where you have plain backgrounds on which the baby is put. You actually get much better results. And we're doing this. So we collected data from Nilofer Hospital in Hyderabad, trained and tested on babies collected from that hospital. And we get a mean error of roughly 94 grams, which is really good. I mean, if you look at actual weights of around 2.5 kg, 3 kg, and so on, an error of 94 grams is pretty good. It turns out to be a percent error of under 4%. And then these are sort of detailed results in a hospital setting binned by the true weight. So this just looks at the error as a distribution of true weight. And in a hospital setting, we also computed binary classification metrics on classifying a baby as low weight or high weight. And this is using that 2.5 kg cutoff. And even there, we get pretty decent metrics. Now, the really hard problem is in a rural community setting where a baby is placed on a multicolored bedsheet, poor lighting conditions, a lot of variability in lighting conditions, a lot of variability in backgrounds, and so on. And there we still get good performance. Our mean error, on a when the average weight is around 3 kg, the mean error in prediction is 150 grams, which is from what we've heard from the public health system. This is a very usable product. We'd like to get this error down to 100 grams as well, which is why the work is still ongoing. But this is pretty good, and in fact, we plan to pilot this pretty soon. So this is, I don't have a video for the home setting, but I do have a video of how this works in a hospital setting. So I'll just show you. It's just setting the context for the problem. Our app is called Digital Tarazu. So this is sort of taking informed consent from the mother and then preparing the baby. Unfortunately, this only works when the baby is not clothed. And then all you have to do is capture a 20-second sort of circular arc video to capture about 30 degrees of angle around the baby. And then this is just measuring ground truth to assess the error. Of course, this would not be done in a practical inference setting. And then the app is showing the weight of the baby. So I'd like to end there with this last slide, summarizing the challenges in the work we do in this AI for social impact space, and hoping that at least some of you will be interested in this space. All the challenges you can imagine are there. So there's challenges of data. We don't have clean data. We often don't have representative data. Our data sets are not large. They're small. Labeling is not standardized. There are privacy concerns. Integration of data sets is very difficult. You can't do simple joins through common primary keys. Time and resource challenges in collecting the data. The challenges on the deployment side. So, deployment is really three phases. Like deployment is integrating into an app. Adoption is that app actually being adopted, being used. And then impact is sort of scaled use of the app. The challenges around all three, right? Just integration into public workflows. So one of the things we do is we don't try to build our own apps as far as possible. We do have to build them for pilots, but we'd eventually like the model to be integrated into apps that already have large reach, like government systems, right? So we have to make sure that our solutions can be integrated well into these systems. So driving usability is a challenge. Teaching on the ground staff to use these things, to a little bit about AI and so on, and doing all this at scale nationwide, worldwide, is a huge challenge. There are subsidiary challenges, like in terms of thinking, getting people on the ground who are not familiar with the tech space to be AI ready, to think through relevance of data, right? Simple data that they collect every day, and driving this kind of AI maturity through government ecosystems and leadership, huge challenge. Post-deployment concerns are huge. Unlike models that you deploy on the internet, you don't have much control over what happens post deployment, but you have to have control in AI systems to make sure you're getting feedback, you know when to retrain your models and so on. And then finally, one of the things we'd love to do is, of course, creating a workforce that can train their own AI models. And maybe to some extent, language models like ChatGPT may have already solved that problem. I think most people nowadays know how to do in context learning, aka prompt engineering. But this remains, in general, remains a challenge throughout India. So I'll stop there. Thank you very much and happy to take questions.
Yeah, thank you so much. I'll just check if there are any questions.
Yeah, I don't see much on the chat.
There was one. Sorry, one second.
There's views on Elon Musk saying stop training large-scale LLMs to give time to formulate AI laws. Well, I think you can't control technology. I mean, um, that's my reaction to it. Once technology is built, it will be used, and then laws and regulations will have to catch up very quickly. My view is that if you delay technology and stop developing new technology, you're going to delay regulation as well. I mean, the only way to force regulation to be enacted rapidly is to drive research rapidly. Any other questions? No?
Yeah, I don't think there are any other questions. So thank you so much for taking the
Great.
time out, sir.
Thank you.
I really think, like, I'm sure this talk has, like, made people think about how we can deploy AI in the social impact sector, and how, yeah. So thank you once again.
Thank
Thank you
you.
to the viewers for joining us. Yeah, this marks the end of day 5 of MLRW. Thank you, and we hope to see you once again, maybe. Yeah.
Thanks.